Well, it is my honor to introduce Dr. Ana Dies-Roux. She is the director of the Center for Social Epidemiology and Population Health at the University of Michigan. Her talk is entitled, Transcending Impasses in Health Disparities Research. Can Systems Thinking Help Us? Ana Dies-Roux.
Okay. Thank you, Aaron, for that introduction. Can you hear me okay? Yeah, all right. So I'm very happy to be here today. I think this is a very exciting conference. I want to apologize in advance for the fact that I have to catch a plane, so I'm not going to be able to stay through the very, very end. So forgive me on that. But it's really a pleasure to be here. I was very excited when I heard about all the initiatives that are going on here at Georgia State. Actually, one of my former postdocs is going to be faculty here starting in September. So this is another connection that I have to the institution. So I'm going to talk to you about a topic that's a little bit different from the things that we've been hearing about this morning, although I think some of the themes that have come out this morning are related to what I'm going to be talking about. And this has to do with both conceptually and methodologically stepping back a little bit and thinking about the ways in which we've been approaching research on health disparities and also the implications of that research for action, which is what we're all ultimately interested in. So I'm going to talk about, just give a very brief overview of what some of the common approaches to understanding and explicating health disparities have been. I'm going to use a very broad definition of health disparities like some of the speakers did this morning. And then I'm going to try to motivate the use of systems thinking and systems approaches and tell you a little bit about what that is. And I'm going to very quickly run through an example. That'll be very quick, but I hope it'll whet your appetite a little bit. I'm going to talk about the many challenges that this raises, and then hopefully return with a few comments about what does this mean for evidence and action in health disparities. So if we think about what are some of the typical sort of guiding conceptual models that people use when they study health disparities or when they try to act on health disparities, I'm going to show you a few graphical depictions of those models, and many of these will be familiar to you. This is one example that focuses on how factors at various levels of organization affect health over the life course, and you can see things from social economic policies all the way to pathophysiologic pathways. This is another example. You have here on the left things like socioeconomic status, education, occupation, income, environmental resources, psychological influences, more proximal exposures and processes, and the health outcomes here at the end. And this highlights, the prior model highlighted levels. This highlights pathways a little bit more. This is yet another example. Hope you can see it. This is from David Williams' work, and he talks about basic causes, social status, surface causes, biological processes, and health status, and the factors at various levels, and also race. This model is focused on race disparities, so race as a central construct and the influence of race on SES as well as on all these other factors. And I think I have one more. This is yet another example looking at social determinants of cardiovascular disease that highlights how socioeconomic position operating at different times over the life course through various mechanisms affects the process of development of cardiovascular disease. So this approach highlights the life course aspect of how disparities emerge. So what are some of the characteristics of these graphical conceptual models that I've shown you? Well, many of them include levels, factors at different levels, something that we talk about a lot, multi-level determinants. They go from distal, from things that are far upstream determinants, to very proximal mechanisms, stress biology, etc. They encompass the life course, many of them. And they're linear in the sense of the arrows all go in one direction, right? This A leads to B, B leads to C, all of these models. And in some way, even though these models are pretty comprehensive, I think often in their operationalization and in research, for good reasons, the emphasis has been on isolating the causal effect of a single factor, right? We want to isolate the effect of changing one of these little things here, rather than understanding the functioning of the system as a whole. And this is in part driven, I think, this emphasis on isolating the effect of a single factor, holding everything else constant, is a lot driven by sort of the experimental paradigm and the experiment as the gold standard for evidence on causation. And that has had lots of good things about it, but perhaps it's also caused us to not see other things and perhaps get stuck in certain ways of looking at things, which has sort of blocked our ability to move forward, what I call certain impasses in our understanding of health disparities. So, and if we think a little bit about health disparities research in particular, from my perspective, there are some big questions that we still haven't completely answered. I think we have to be honest about this, and I'm going to give you 3 examples of questions that I think on which there's still quite a bit of debate, certainly out there in the more biomedical community about the relevance of the work that we do. The first is, well, how important are place-based factors really? I mean, many of us work in neighborhoods and health, and we believe that there's a strong impact of places on health, but that's certainly not commonly accepted out there in the public or in the real world, and there's a lot of debate about whether these things are important or not. What about genes? I mean, the reality is that we see important health disparities in many conditions, and there's this divide among the geneticists who still think they can explain this with genes, and the social people who want to who negate the impact of genes, to make it very extreme. And in fact, when we look, for example, at health disparities in hypertension, the geneticists can't explain the disparities, but the social epidemiologists can't explain them fully either. And so we've gotten a little bit stuck in this paradigm where we're trying to partial things out. Is it this or that? So maybe there's another way to think about this that helps us integrate these things and see them in a different way. And the third question is, what is the impact of early life? What's the real impact of early life? I mean, there have been many studies looking at documenting associations between early life factors and later health, but are these things causal? Do we really expect a big impact? There's still quite a bit of debate about the relative importance of early versus late life factors. So if we talk about places in health for a minute, which is an area in which my group has worked in, let's take a very simple schematic example. Let's suppose we're interested in understanding how neighborhood food availability affects dietary behaviors. And there's quite a bit of evidence that there's at least an association here. And structural features of neighborhoods may affect food availability, and then diet obviously affects other outcomes. But we have other factors like family income. Then we have these bothersome arrows going the other direction, which we usually try to avoid because we don't really know what to do about them, because perhaps dietary behaviors affect food availability to a certain extent. And family income affects structural features of neighborhoods. And then, of course, there are other neighborhood factors, and there's a broader context of society-wide production and distribution of food, which may be perhaps much more important than the neighborhood differences in driving overall dietary patterns. So this is a system, right? This is a simple system, but nevertheless it's a system. And I'll talk about what I mean specifically by system in a minute. Another example, neighborhoods and physical activity. A lot of the work on neighborhoods and health has really tried to isolate these two processes. Health may be affected by features of the neighborhood. Here there's a specific example for physical activity. Availability of places to be physically active may promote physical activity, and people are sorted into neighborhoods based on other characteristics which may also be related to health. So a lot of the work on neighborhoods and health has really tried to isolate the effect of this from this, right? That's really been kind of what we've been trying to do, multi-level analysis, all sorts of other analytical approaches. But obviously there are other things going on. So people may, at least in part, select neighborhoods based on preferences for certain attributes to the extent that they can. People change their behavior in the response to others around them. If you see more people walk, you may be more likely to walk. When I moved to Ann Arbor, for New York City, nobody walks in Ann Arbor. Well, I shouldn't say that. It's a comparative thing. If the Ann Arbor people heard me, they'd kill me. But so, sometimes my husband and I walking home, we say, oh, there's nobody walking. It's so depressing. So maybe next time we don't walk, right? And then neighborhoods change in response to the behaviors of residents. I mean, there are certain things, not always, but there are some things that neighbors can do to impact their neighborhoods. And these things, these dynamics, are things that we aren't really capturing in the way that we're looking at things. So we can really think as the spatial patterning of health emerging from this kind of bidirectional influence between individuals and environment, in which individuals interact with their environment, they interact with each other, and individuals and environments adapt and change over time. And here, I'm not using the word interaction in the statistical sense, but in the more dynamic sense of feedbacks that go back and forth, right? Coming back to this and kind of putting it all together, personal resources, obviously, and preferences may affect residential location and the composition of areas, modulated by things, for example, like discrimination, which obviously affects where people can live. The residential location area composition affects the resources and advocacy resources that are available. There's a feedback. These resources, in turn, may reinforce residential segregation because those who have, the power will locate in areas with better resources, so it becomes a vicious cycle. These resources may affect the location of health-specific resources, food stores, healthcare providers, recreational facilities. These things also may feed back. Here we have these, bothersome kind of feedback yellow arrows. Location of resources may affect health behaviors, which may in turn reinforce certain kinds of resources in areas. And then we might have stress processes, which also modulate the way in which resources affect health. If you're stressed at work and you get home and nearby the only thing you have is fast food, well, you're going to pick up something on your way home, right? So there's modulation there, and then health, and might be some other feedback arrows going back here. So this is really, again, it's a system that we're trying to study. And if you think about the other outstanding questions, if you think about genes, we could come up with a hypothetical example to illustrate some of how this would work as well. So suppose, and I'm sure someone has identified a genetic factor that predisposes to physical activity. Pretty sure someone has found it, because I'm sure there's a SNP out there that's connected to physical activity. So a simplistic understanding would say, okay, this genetic factor predisposes to physical activity, but really, what is this embedded in? Well, there's obviously ancestry, which is related to genes and parental genes, but there is also culture. There are family norms, which may also be affected by culture and potentially by genes as well. And these norms affect physical activity, which in turn feeds back into the norms themselves. There's modulation here. The norms may modify the extent to which the gene affects physical activity. And then, of course, we have environments and peer groups that exert similar kinds of influences and other exogenous factors. So here we see that it's very simplistic in the context of the system to try to isolate the effect of a gene. And we're not really understanding the impact of the gene if we're not seeing it in the broader context. And we may misattribute causal importance to various factors by not seeing them all together. One last example that I'm going to show you has to do with the impact of early life factors. So we know that parental socioeconomic circumstances affect the health of their offspring and also the educational achievement of kids. These things also affect the peers that they're exposed to, their feedbacks as well. And this then transmits to the next generation where we have similar feedbacks going on. So if we want to understand the impact of early life circumstances, we may need to consider all these reverberating kind of loops through which these things may perpetuate and magnify effects. So what are some features of these models? These are made-up models, of course, and you might come up with a slightly different formulation. But what are some key features of these models? One is the presence of feedbacks. There's a bit of a humming sound. Can you guys hear it? Yeah. Oh, I have my phone here to look at the time. Okay, I need. Yeah. Well, why don't you tell me when I have 10 more minutes? So there are feedbacks, positive or negative feedbacks, and adaptation over time. There are dependencies in the sense that people influence each other. Neighborhoods that are close to each other may influence each other as well. And this results in emergent patterns, which are the health disparities that we see, right? Those are emergent patterns that are not easily reducible to the effect of a single factor. And perhaps this is the reason why we haven't been able to come up with very compelling and complete explanations for the large health disparities that we see, because we're trying to look at the effect of a single factor as opposed to the dynamic interconnections between these factors. So I don't think it was my phone because I can still hear it, but it's all right. It's an experiment. This. Okay, fine. So we can really think of these as dynamic systems that are leading to the emergence of health disparities. And if you look at the literature on dynamic systems, there are certain things that people highlight as key. Factors at multiple levels, heterogeneous and interdependent units. People are all different, but they interact, they depend on each other, yet they influence each other. Recursive relationships, feedback, endogeneity, as the economists like to talk about it, right? What I do affects my environment as much as my environment affects me. Nonlinear effects, because when you have these dynamics, you see things that happen much later in time, maybe you wouldn't have predicted. And unanticipated effects, things that we didn't expect. So this sounds a lot like the stuff that goes on that we think is driving health disparities. And another feature of dynamic systems is policy resistance. And John Sturman has a very nice paper several years ago in AJPH, which some of you may have seen, where he defines policy resistance as the tendency for interventions to be defeated by the system's response to the intervention itself, or when obvious solutions fail or even worsen the situation. Sounds familiar, right? We've all, we've seen this happen. We've seen that often when we do interventions that we think are going to ameliorate health disparities, they actually increase health disparities, for example. And if you look back at one of the sort of the founding fathers of systems thinking, Forrester, he said back in 1969, in the complex system, causes are usually found not in prior events, but in the structure and policies of the system. And I think this resonates a lot with how a lot of people think about health disparities. It's not a single factor, it's something about the structure of the system that's generating these disparities. So does this mean, and I think in public health, we've lost this vision a little bit in our quest for identifying the causal effect of a single factor. And so are there ways that we could incorporate some of the systems view back into our conceptualization and also perhaps into some of the analytical tools that we use, and what would the implications of that be? And I'm going to tell you, I don't know, I'm not sure about the answer to that question, but I think it's something that we need to think about. So what is a systems approach? I mean, there's lots of talk about systems. What do we mean exactly? And here's a quote from a paper on systems biology. It says, systems approach does not investigate the individual genes or proteins one at a time, as has been the highly successful mode of biology. Rather, it investigates the behavior and relationships of all the elements in a particular biologic system while it is functioning. And similarly, paraphrasing that, a systems approach to the study of health would not investigate individual risk factors or individuals one at a time. Rather, it would investigate the behavior and relationships of multiple factors and multiple elements in a particular population system while it is functioning. So how do we do that? Is there a way to do that? So in some ways, the systems approach is quite different than the way I think that we've come to think about research in health disparities. And it really starts out, I mean, I think we may do this to some extent, but not in such an explicit way. The systems approach really starts out by defining the components of the system, coming up with a dynamic conceptual model. This means a model that may have feedbacks in it. Now, it's not a question about putting every single possible feedback in there. You have to abstract the, quote, essential elements and set bounds. And the model has to be specific to the question you're trying to answer. So this is not necessarily about making very, very complicated conceptual models. It's about making models that capture some dynamic processes that we think are essential to what it is that we're studying. And this is really hard to do. But probably the development of these dynamic conceptual models is the most important thing. Even if we don't end up using any of the tools of complex systems approaches, if all we do is start thinking in a much more dynamic way, I think this will be a great benefit of this way of thinking. Once one has a dynamic conceptual model, there are ways to develop a formal simulation model to integrate existing knowledge about the different pieces and to simulate and explore the functioning of the system and to answer fundamental questions about what's driving some of the patterns. And I'll show you a very quick example of this, as I said. And then hopefully we can draw conclusions using this model about the drivers of patterns, the causes, and the plausible impact of interventions. And I've highlighted plausible because I think, at least from my perspective, the utility of these kinds of modeling approaches is not about specific prediction. What's going to happen if I do this? It's about understanding what are some of the plausible things that could happen. And then we may need other kinds of tests to really determine to really do more specific predictions. So this is more about understanding how the system works and where some good leverages for intervention could be. So key elements of systems approaches is really understanding processes. In a way, I think in a lot of public health research, we've become so focused on documenting associations that we've forgotten that these associations are supposed to be reflecting underlying processes. And this is a way that forces us, something that forces us to think about processes again. If we have a model that's we think is approximately realistic, we can test interventions which may not be feasible yet in the real world. And we can identify new places. We hadn't even thought of intervening there, and actually it might have a beneficial effect. And there are many different systems tools. Two common ones are systems dynamic modeling and agent-based modeling. Of course, this has been done in infectious diseases for a long time, for good reasons, because of the contagious nature of infectious diseases. But only recently have people begun to think about these tools in the context of looking at behavioral outcomes or chronic disease outcomes or health disparities specifically. So I'm going to show you one example with agent-based models, and I'm not going to get into a lot of the technical details, but I'll just tell you very briefly what these are. These are essentially computer representations of systems or agents that interact in space and time. They can be defined at different levels. They can be people, institutions, providers, etc. These agents change or take action in response to various things, their own attributes, their interaction with other agents, the environment, or prior experience. And we use simulation to observe how patterns emerge from these interactions, and then potentially also look at the effects of different interventions on this system. So contrast the impact of different interventions in the context of this virtual system. There are many different kinds of agent-based models, from abstract ones that are really just trying to help us to gain intuition about a process, from prediction, highly detailed prediction ones. And the example I'm going to show you is more in this realm. It's a bit of an exploratory thing to help us gain intuition. It's not intended to be a specific predictive model in any sense, okay? So this is an application to the study of neighborhood health effects or spatial patterning of health. And there are a number of reasons why agent-based models are particularly nice for this kind of application for neighborhood health effects, because they capture this bidirectional person-environment interaction that is often raised in critiques of existing literature on neighborhood health effects, that people select themselves into neighborhoods, that what people do affects their neighborhood, this endogeneity issue. And these models can allow us to explicitly incorporate that and see what impact it really has. We can model interactions between people and also interrelations between the physical and the social environment. They're not separate things, right? If you open a park in a neighborhood, that might affect social interactions and change the social environment. So it allows us to factor in these influences that we often, kind of control out in our statistical models. And agent-based models are particularly nice for spatially patterned processes. So I'm going to use an example led by my colleague Amy Auchincloss, who's currently at Drexel University. We did this work a few years ago. It was published a couple of years ago. And so we started out with the question of income differences in diet, which, as you know, are well established and could be a potential contributor to health disparities. And there's lots of evidence showing spatial segregation of healthy foods. But there's still questions regarding causality. Is this causal or not? I mean, is there some selection process going on as well? And so we developed this two exploratory questions, and we said, okay, we're going to use this simulation model to answer a hypothetical question. Often when people talk about the impact of food access on diet, they say, well, it's people's preferences that are driving this, right? There aren't these fresh fruits and vegetables in these neighborhoods because people don't want these things. And so it's preferences that are driving the location of food stores, so it's not just about access. So we said, okay, let's create a world where we have no differences in preferences or price. We just have spatial segregation of stores and people. Would that be enough to generate the kind of disparity in diet that we see? Because if it is enough, then that provides a piece of evidence that's supportive of the idea that these things really do matter. And then secondarily, if we see these differences, if we do interventions on price and preference, some subsidy and a health education campaign, say, what would be the impact on these disparities? And so Amy developed a model with two types of agents, households and stores. And households have certain characteristics. They have a certain level of income. They have a certain healthy food preference, which in the base model is just kept constant, as I indicated before. They have a certain diet. The households shop every certain number of days. They select a store based on an algorithm, which is based on available data to the extent that we have data. The stores also have a certain food that they sell. They have a certain price, and they react to the consumer behavior. They may close down if they don't have enough people buying there. And then the household diet changes as a function of the kind of store that they buy in. So it's a relatively simple model with two types of agents. And we first said, okay, we're going to compare income differences in this model under various spatial segregation scenarios. And then we're going to see what happens when we vary price and preference. So we contrasted various spatial segregation scenarios that vary in the extent to which households are segregated based on their income and stores are segregated. And I'm not going to go into detail on this, but we have a couple of scenarios, one scenario where we have healthy foods segregated with high-income people, which is what matches the empirical kind of literature in this area. And then we compared what magnitude of diet differences, income differences in diet, do we see under these various scenarios. So this figure is a little complicated, but if you just focus on these black boxes, they show the income difference in rich versus poor people. The numbers above the line, the boxes above the line indicate that higher income people have a better diet than lower income people. And we saw that the scenario that generated the income difference based on our model is exactly what we would predict. When healthy stores are co-segregated with high income people, we see this income difference even in the absence of differences in preference or price. So clearly, spatial patterning, at least under the assumptions of our model, these income differences emerge in the presence of co-segregation of low-income and unhealthy stores, even when food preference or price are held constant. So we saw that emerge in our model. So we think our model is capturing some of the dynamics that we think may be going on. And so then we turn to the next question. Well, what happens when we manipulate price and preference? And so we did a series of experiments. This is the same scenario that I just showed you, where we have the rich people living with better access to healthy food stores. And we said, okay, let's launch a campaign, and let's make high-income people prefer healthy food and low-income people prefer unhealthy food. We see the differential become greater, as we would expect. But even when we made both groups prefer healthy food, the income difference was still there. So changing preferences was not enough to overcome the spatial access issue in our model. It didn't eliminate the disparity. It basically didn't move it very much at all. Then we tried price interventions, and we said, okay, let's make healthy food expensive and unhealthy food cheap. Well, we see that the difference becomes even greater. And then we said, let's try the opposite. Let's make healthy food cheap and unhealthy food expensive. And the difference flipped. It flipped completely. And why did it flip? Well, it's kind of interesting why it flipped. It flipped because the expensive, unhealthy stores closed in the poor neighborhoods in our model. So the stores reacted to this intervention and closed, and that improved the benefit to the poor neighborhoods because they had more healthy than unhealthy stores. And then we tried combinations of different approaches, which I'm not going to get into, and you can read about in the paper. So this is exploratory, and in no sense is it, would I say that this has provided the answer of what would happen in the real world if we did these interventions, but what did we learn from this simple application of a systems model? Well, we learned that segregation can create disparities in diet even in the presence of no differences in preferences or price. We learned that changing preferences, at least in our model, was not enough to change the disparity. We saw that price manipulation seemed to have a stronger impact than preference manipulation, but they reinforced each other. And you can see why we concluded this in the paper. I didn't have time to get into the details of the combined approaches. Most importantly, this exercise really forced us to think about the processes and, because you have to program this. You have to think about, well, how do people decide where to shop? What drives their decision? What happens when they shop? How do stores react to what people do? And we realized that there were lots of pieces about which we had no information whatsoever. And so it generated ideas for new questions and new data collection that we need to do. And I think probably these are the most important byproducts at this point of these kinds of approaches. We thought about the processes. We had ideas for new data collection in order to be able to improve and refine our thinking about this process going forward. So what are some of the benefits? Well, first of all, when you start doing this, you have to think dynamically, which we don't do very often. So we were forced to really think about processes and move from describing associations to modeling the processes that generate them. We had to explicitly account for the interrelatedness of people and environments. And then all the other very interesting aspect of this approach, which is not really illustrated by the example that I showed you, is that there's actually a long tradition in systems modeling of developing a dynamic model, incorporating input from stakeholders, communities, different stakeholders in the community, and scientists together to create the initial kind of schema of the dynamic conceptual model, which can then be studied more formally. So it's a way for various groups to provide input into the conceptual model that underlies the problem that we're interested in. Another benefit is that provides a whole new set of tools. Agent-based modeling is one example, but there are other tools as well. We can often gain insights through using these simulation tools, and we can do these thought experiments in the context of these dynamic relationships under conditions that may be different from those observed in the real world and accounting for these feedback loops. And finally, another nice thing about these approaches is that they allow us to integrate various kinds of information from various sources and also sometimes qualitative information when we put together this model and then do a formal simulation model, and allows us to identify gaps as well. So these are the nice things about it. but there are also lots of problems. And, this is the reason why people have been doing this a long time. There are reasons. It's difficult. There are a number of caveats. One is, how do you keep these models simple enough that they're tractable and you can make sense of them? As I said earlier, there's a big temptation to include everything, and that's not what you want to do. 10 minutes. That's not what you want to do. You really need to work hard to include the essential elements. And of course, somebody may come and say, oh, you forgot that. What happens if you add that? And that's part of scientific debate, and that's a good thing. But really, keeping these simple but relevant is a big challenge. And really, I think, at least from my perspective, the utility is really in the thought experiment kind of realm more than in the specific prediction idea. Another big challenge is that these models have assumptions, obviously, just like our statistical models have assumptions. There are different kinds of assumptions, but they are also assumptions. And so sometimes we have very little information on which to justify the model processes. Calibrating and validating the model is often a big challenge as well. It's a very arduous process. It's very different from running regressions and cranking out papers real quick, right? It's hard. And then transparency and communication is a big challenge. Being able to communicate what you've done to people in a way that they can replicate it and use it and build on it. And finally, the biggest challenge is, well, does it make a difference? Have we learned something new? Or are we getting out of the model just what we put into it? And the idea, of course, is that if we really need a model, a systems model, we should be able to gain new insights from looking at the outputs that we wouldn't have predicted based on what we're putting into it. And there may be many situations when that's true. There may be other situations when that's not true, and then you don't need to do any of this. So where does this leave us? Am I saying that we should abandon everything we have done and think about systems modeling approaches? And the answer to that is absolutely not. I think we need to think about the different ways in which we can gather evidence for understanding and for action in health disparities research. We are very comfortable, of course, with observation. We often talk about observation leading to experiments. There's also an arrow going this way, which we don't talk about as much, but it's certainly there. To give you a specific example, many of you may have seen the Moving to Opportunity experiment published in the New England Journal, I guess it was a couple of years ago, looking at the effect of moving people out of poor neighborhoods, and they found some interesting effects on diabetes and BMI. But if you look at the conclusions of the paper, it says, an experiment, it says, well, we don't really understand the mechanisms for this. And that's key, because if we're going to intervene, we need to understand the mechanisms. It's not just about moving people, it's intervening on their neighborhoods. And to understand the mechanisms, we have to go back to observations. I would suggest that we also need to think about how observation may lead to systems modeling, as I showed you in an example. Systems modeling may cause you to say, oh, I need to go back and collect more data on this particular aspect because I hadn't even thought about this as being an important factor in what I'm trying to study. And systems modeling, suggestions from systems modeling may lead to experiments, and experiments may feed into improving a systems modeling approach as well. So we need multiple sources of evidence. And then, of course, because we are in public health, there's also action. A lot of time we need to take action in the absence of complete evidence. In fact, we should take action, and we can learn and evaluate that action rigorously, and that itself can feed into these other sources of evidence. So, for example, many of the interventions to increase healthy food access in poor neighborhoods that are currently ongoing, through an evaluation of those interventions, that may suggest new experiments or feed into modeling and simulation as well. So, to finish up, I guess some of the main points that I wanted to get across is that clearly health disparities emerge from the functioning of a system. Systems can be investigated using a variety of approaches, but we have to remember, put the stuff back into the system when we interpret it. Put kind of Humpty Dumpty back together again, right, after we've looked at the different pieces. Focusing on a single method can constrain the way we think about things. And I think that's happened a little bit, certainly to epidemiology, where people have started formulating hypotheses just as independent associations. And so the questions that we're asking have become narrower and narrower and narrower because we're driven by the method that we're using, as opposed to thinking about, well, what's the question we want to answer? What are all the different tools that we need to answer this question? And I think, it's important for us not to get stuck in a single method and keep doing the same thing over and over and over again and keep getting the same predictable answer over and over and over again, but rather think more creatively and broadly about the complex problems that we study and try to bring new ways of both conceptualizing and analyzing information to move beyond some of these impasses that we're kind of stuck on. And I always like to end when I talk about this with this quote from an epidemiologist, Roel Stalones, who published very little, but it was a time when people published just a few things, but they were jewels. And these are just a couple of quotes from him. He said, the burden of disease on a human population is part of an environmental system, and the interrelatedness of the components of the system cannot be understood by pursuing research whose rationale is to divide and isolate the components in ever greater detail. And if we consider disease to be embedded in a complex network in which biologic, social, and physical factors all interact, then we are impelled to develop new models and adopt different analytic methods. So it's interesting that he said this, what is this now, 40 years ago? Oh my God, 40 years ago. So I think this is a challenge for us to think about how to bring in a broad variety of tools that help us think about the systemic nature of health disparities in order to gain information that's important not only for understanding the causes, but also for developing actions to eliminate disparities. Thank you for your attention. I'll be happy to take comments or questions. It's after lunch. The digestive system is working.
I wanted to know about your personal thoughts and if there's any evidence that associate personal experience of a researcher in this field. For example, I don't see sometimes I don't see and I don't understand sometimes people who have never experienced poverty or limitation do research, and based on those words on the literature, do you think it will make significant difference in the quality and specificity of the research, of that personal experience?
Well, that's a very good question. I mean, I think obviously because scientists are people, their subjectivity and their experiences color the kinds of questions that they ask. They also color the way they interpret what they find and what they do about it. I also think, and this is why I think of myself as a scientist, at least in part, I also think there is an objective reality out there that we're trying to capture. And so I think it's a balance of both things. It's a balance of our subjectivity influencing what we look at and how we interpret it, and it's also the influence of objective reality that's driving what we see. And we're trying to grasp that objective reality. I also think it's true, and this is why it's important to have scientists from many different backgrounds involved in this kind of work, that often people from different backgrounds will see different things and have very different kinds of questions, and all of them are important to understanding what we're studying. So I think a person's background is very important, and we need a diversity of different backgrounds in this field in order to really understand the problem that we're trying to fix.
Anna, that was absolutely fantastic. Very nice presentation. I'm intrigued by this quote. I just keep rereading it, that it was 40 years ago. And I just sort of think, well, if and really so little attention in some ways was paid to this for the last 30, 35 years. I'm just wondering, it's a bit of a rhetorical question, but why are we to believe that anything different will happen now? I mean, I think it will because the tides have turned and the Titanic has moved.
Yeah.
But in a bigger picture, in a country, and I'm speaking of this country, that is so biomedically based, and this is coming from someone who was a practicing physician until recently, to sort of get people to even think like this is going to really be a massive change. And the medical enterprise, as you know, is a multi-billion-dollar enterprise that doesn't want to let go necessarily so easily. So any reflections on that?
Yeah, I mean, I think that's a very important point. I guess I have a couple of comments in relation to that. I think, well, first of all, I think we have to engage with the biomedical world and do the best we can to illustrate why, if we don't think in this more systemic way, we're getting the wrong answers. I mean, the answers that we're getting are wrong. And so it's our challenge to us to be able to demonstrate that. Why hasn't this, so there are a couple of reasons why I think we may be moving in a different direction. One is that I think, at least to me, it's becoming increasingly evident that if we keep doing what we're doing, we're not going to move forward very much. I mean, we're kind of stuck, right? I mean, I often talk about this with my students. They say, I'm going to do this analysis, then I'm going to adjust for this. And I say, I can tell you exactly what's going to happen when you adjust for this. I can predict exactly what you're going to get. You're not going to learn anything, right? And I think we've come to a point with some of these questions that if we don't do something different, we're not moving forward. We're just doing the same thing over and over again. And I think now there are a number of new tools that we can use that perhaps weren't as accessible and available before. Now, I say that with a certain trepidation because I certainly do not want to give the impression that this is going to solve all the problems. Applying these tools is going to solve all the problems. This is just one more element that we can bring into our toolkit. But I think the bottom line is that we need to, be able to demonstrate how this kind of thinking provides the answers which are more meaningful than ignoring this stuff. And then I think we have a big job to do in terms of getting this information out to the public and to the biomedical community, but also to the public. Because, if you go out and ask, do a survey, I would bet, about what are the main causes of health disparities, we all know what some of the answers that we would get are going to be, right? It's going to be healthcare, which is important, but it's certainly not. It's going to be genes, So I think how to break that paradigm is a big challenge for us. So I was fortunate to be on this panel that put out this report on the U.S. health disadvantage, which got, fortunately, quite a bit of press. But one of the striking features of this report is how the U.S. does poorly on lots of different things and unrelated things, or maybe they are related, but in a systemic way. And so we need to think that way in order to understand this systemic disadvantage. And so highlighting that kind of stuff as much as we can is one way to try to break that paradigm. But it is a hard job that we have.
What you just said, I think, is really critical because, in a way, we may be deluding ourselves. I think that this incredible complexity, you feel as if you're being attacked by Spider-Man when you see these things. This incredible complexity reduces down to jobs and income and health and a variety of very clear things that all of us intuitively understand. And so what we're doing is we're building this very complex system around, which is a real one and it's true, but we're building it around things for which there's actually a very simple solution over which we have absolutely no control. So are we fooling ourselves?
Yeah.
Are we fooling ourselves?
I'm glad you brought that up because I think that's another very important point. I mean, I certainly don't want to give the impression that we need to always think about complexity. I think there are some very simple things that we know and that we're not acting on for reasons that have nothing to do with knowledge, right? However, that being said, and inequality, we know that inequality is bad for many reasons. It's bad even if it doesn't affect health, So there are things that we should be doing that we're not doing based on what we already know. Now, that being said, I do think that there are some questions in health disparities research, particularly things about race and ethnic differences in particular, for which we don't have a very convincing answer. And there is quite a bit of debate about what's driving these things. And depending who you ask, you get a very different answer. And so I think in those things, maybe thinking about this differently may lead to new insights that will help us break that impasse. You know, I use the example of race differences in hypertension because I think it's a really good example. I mean, the reality is these are really big differences. And yet, have the geneticists been able to explain them? No. Have the social scientists and psychologists been able to explain them? The answer is no also, if we're honest. So there's obviously something going on there that we're not getting right in terms of providing an explanation. And so I think for some of those questions, this kind of thinking may provide new insights. But I agree completely with you that for some things, we don't need this. We already know, we already know what we need to know, and we just need to act on it.
I wasn't trying to say we don't need it.
Okay.
But, actually,
maybe I feel sometimes that we don't need it.
One of Einstein's great quotes was, "Things should be as simple as possible, but no simpler."
That's right.
And clearly, it's got to be more complex than that.
Right. I think there was, one here. I think there was somebody over there.
I wanted to ask your take about the undergraduate global health undergraduate program in public health, because I'm teaching a course in Emory. In undergraduate, my students have been involved in a lot of community-engaged programs and trying to eliminate health disparities in the refugee and immigrant communities in Clarkston area. And it's been really a frustrating and challenging experience for me in the last 4 years. But yet, it has been very rewarding as well, because the community trusts, my students trust me, and means the students who take my courses come and ask for service. And I don't want to say that I fix anything, or it's not me. It's the collaborative team effort that we do. We have partnerships in the community, in the Board of Health, in state offices. There's a lot of hardships, and really like the quote, as Dr. Haluwalia also said, but there is hope. And the hope is that my students are learning cultural competency at undergraduate level. When they go out and we have meetings with the partners, sometimes they don't understand that we can do all these interventions even at undergraduate level when students have not even yet decided what their future course of action would be. But I am really an advocate for undergraduate public health, and I'm enjoying this. This is my passion. And the passion has recently been rewarded. I have been given a national honor by Society for Public Health Education.
Oh, great.
So this gets rewarded. So I'm just asking your take on what is the future of undergraduate public health?
Well, I think there's increasing interest all over the country in undergraduate public health education. I think you see it coming up, many universities, because there's so much interest and demand on the part of the students. So I think that's a very positive sign.
Hi. Thank you for this presentation. I have a quick question regarding the some healthcare accessibility. Even though we are emphasizing the healthcare accessibility, but due to some barrier, some are getting worse and worse, such as a legal barrier. As a community organizer and practitioner, building the facility which is accessible for the community. But actually, the one thing we are missing. One is the physician-dominated system. That is not really work for our community.
Sorry, can you say that again?
Dominated system because of in terms of the legal issue. So when we talking about the efficient model for the community, actually I was emphasizing the utilizing the nurse practitioner and then nurse managed center. Actually, it's for some prevention and then education stuff. Also like a little minimum level of the diagnosis. But it was not really possible to do that. So without that concern and the solution, how can we build some efficient healthcare delivery system for the community?
How can we
building the efficient healthcare delivery system for our community? I'm just asking you a question about our current physician-dominated system can be changed. Is it feasible?
Well, that's a very hard question. I'm not sure Well, we'll have to think about what system that's embedded in. I'm just going to answer it that way. I mean, I think it's a very good question. I think many countries have struggled with that question over time. Physician-dominated versus what's the influence of physicians on the system and what should their role be? I mean, I think that's a very big question. I'm not sure that I have an answer to that.